so I think it's time for us to get started. Welcome to everybody out there in cyberspace on May the 4th, Star Wars Day, to our MIS, All Things MIS Liver Stages webinar. We are so excited to bring everybody here together today remotely in the middle of COVID to talk about minimally invasive liver surgery as we're all getting ramped back up. We have some amazing panelists today. The original intent of today's seminar was to give our viewers a chance to see the benefits and drawbacks of laparoscopic versus robotic liver surgery. I think we have a really awesome panel. We're going to start with Dr. Subhashini Alu, who's going to tell us benefits of both modalities. We're going to then move into Dr. Adnan Al-Saidi, who is going to talk to us about the benefits of laparoscopic liver surgery all by itself, not lap-assisted anything. And then we're going to have Alan Sung from, it pains me to say this, The Ohio State University, talk to us a little bit about the benefits of robotic surgery. And then Flavio Roca is going to break down all the data for us in the way that only he can. And then Iswanto Sakandi is going to join us with some really amazing videos at the end. So without further ado, I'll invite Dr. Alu, who joins us from Rutgers, to please share her screen and give us a little lesson on lap and robotic. As she's sharing, I'll remind everybody who's listening that Dr. Alu has an amazing breadth of minimally invasive experience, and we're very lucky to have her here today. She was doing minimally invasive surgery before it was cool, and now she's just amazing at it. So we're really excited to learn from her.
Thank you, Suzanne. First of all, welcome Facebook HPB Sages HPB group. And I'd like to thank Suzanne and Kevin for hosting this education series. And let's see if I can share my screen. Okay. So I was asked to give a talk on MIS hepatectomy, what each modality can teach us. Before I advance with my talk, I like to dedicate this talk to 248 souls that inspire me to do my best in the field of my passion, which is surgery. So without ado, I'll move forward. So I have no financial relevant disclosures for this talk. The objectives are very simple. We're going to discuss about the modalities for different modalities for hepatectomy, and we're going to touch base on what each modality can offer us and how do we decide which one to employ for a evolving field of minimal invasive hepatectomy. To start out with, open hepatectomy is the gold standard still, and everything that has evolved from then on has been compared to what the outcomes have been from open surgery. MIS is fairly recent. It started in 1990s, and the two predominant platforms have been laparoscopic and robotic. But within laparoscopy, people have done multi-port, which is majority of the people have done multi-port, but there are decent amount of literature on single incision laparoscopic surgery as well. Just to surprise you, there is also notes done for hepatectomy, but mostly in animate model, and the fact that it hasn't transferred to humans yet tells us about the complexity of employing nodes in this particular operation. In order to discuss about laparoscopic hepatectomies, even though it started in 1990s, the first consensus was done in Louisville in 2008. And at that point, a group of brave surgeons got together and put out this statement saying that laparoscopic liver surgery is safe and effective, but it's in expert hands, and then we need some educational program in order to advance that. Moving further, a decade later, 2014, the second consensus in international laparoscopic liver surgery has happened in Japan. And at that point, the left lateral sectionectomy has become a standard practice, whereas the major liver resections were still considered as innovative procedures, which are in exploration phase, and acknowledges that this has a steep learning curve. Now, in order to talk about the one thing that one should pick up from this laparoscopic liver surgery is it has superior outcomes than open hepatectomy in terms of reduced intraoperative bleeding, shorter hospital stay, and the significant advancement of employing this platform is in cirrhotic patients, where it has shown to decrease post-operative complications such as post-operative ascites and liver failure. And that is a huge, significant advantage. In order to give you a timeline about the evolution of laparoscopic hepatectomy, one can appreciate it started in 1990s, and then as a couple of decades further, we have started addressing complex cases. And also it's important to notice that this advancement was only feasible because we also have technology assisting us on the sidelines. So just to summarize, it's a relatively new technique, even though it started in 1990s compared to our experience in open hepatectomy. It's still a relatively new technique, and it relies heavily on technology, and it's essential to have advanced technical skill. What are the benefits? It is similar to any other MIS procedure in any other field of surgery, such as shorter length of stay, reduced bleeding loss, reduced transfusions, pain. I don't say that lightly because it usually ends up being a subcostal incision in these cases. And so pain is a significant consideration in these operations, which again helps in reducing cardiopulmonary adverse events and long-term, which we try not to put it in our brains, but hernias and then reoperations. One thing that I notice from doing MIS hepatectomy is if one has to go back to reoperate, it lends easily to reoperative procedures compared to a person who had an open previous surgeries. And as I mentioned before, it's very advantageous in cirrhotic patients with less postoperative ascites because there is better venous drainage. One thing is equivalent, whether you do open or MIS. We have established so far that oncologically, both these operations are same in terms of margin infiltration and recurrence. But one thing that is for sure is most of these operations are prolonged operations. So compared to open operations, these are longer operating time. Now, some of the things that I think are advantage with laparoscopic platform is, first of all, it established in the history of MIS hepatectomy that it is feasible. Nobody docked the robotics first or any other platform. They went with laparoscopy because it is easily transferable from doing other general surgical procedures or other specialty procedures that are done in MIS. So it was an easy transfer. And you don't need a specialized team for this. And there are certain surgical teams that heavily rely on specialized instruments such as CUSA. I know surgeons who wouldn't do any hepatectomies if they don't have CUSA. And so these instruments are readily available for laparoscopic platform. And the movements are intuitive, just like any other laparoscopic procedure. But because hepatectomy, we are very concerned about bleeding and entering into a major blood vessel, there's a sense of control when a surgeon stands very close to the patient, and conversion to hybrid procedure is easily done. Just to complete the circuit on international laparoscopic liver surgery, to finish up the advances so far in 2019, the group has discussed about several things. One is now that there are certain operations on hepatectomy as is standard, and some are still in innovative phase with expert MIS skills. How do we diffuse this knowledge and this technical skills? But if you move along this this table, the last thing that they talk about is robotics, laparoscopic liver resection the way to go, and how do we develop better advanced instruments? And that's important because although laparoscopy has lent us to transition from open to minimal invasive surgery, it is severely handicapped. Sorry, Adnan, I had to put this slide on to be fair on the discussion. but because especially you feel the handicap of these ergonomics when you're doing a major hepatectomy cases or complex HPV cases because of just the innate properties of this platform, which is limited degrees of freedom, very unstable platform, the 2D vision, and poor ergonomics. And at the end of these complex prolonged cases, when you are trying to compensate for the deficiencies of the instruments that we are using, it leads to mental and physical exhaustion as well. So that lends us to talk about computer-assisted platforms because these have an advantage. They have higher degrees of freedom. It's a stable platform, 3D magnification, and tremor-free. So what is the advantages? Well, the role of robotic platform is going to be more pronounced in major and extended hepatectomies or in segments that are difficult to reach. And in addition to that, it also includes near-infrared fluorescence, which can help us better visualize the vascular and biliary anatomy. What does this all translate into? I think it translates into precision. You can microsuture, work in a very narrow field under the liver, addressing the venous vessels, and you can better do the dissection with hepatic hilum and conversion to open. Now, again, all these experiences are shared from individual series or institutional series. We don't have a consensus statement on these yet. So this is a study, it's a meta-analysis between open hepatectomy versus laparoscopic hepatectomy versus robotic hepatectomy that has shown that laparoscopic and robotic hepatectomy has superior outcomes than open hepatectomy, and the cost was not significantly increased in robotic hepatectomy. So what are the disadvantages? Well, I can tell you, you can't just do one day open and laparoscopic and then jump to robotics. You do need some specialized skills. You need to understand the system. You need to have a team that can troubleshoot any problems in the middle of the case. And then, so there is a simulation that goes in between before one can jump into live cases. And so you have to invest some energy into it. It's still a bulky system and you are working with a heavy 3D contour organ. So it is still a little bit cumbersome to work with robotics, and robotic instruments for, in my opinion, for liver surgery needs to be developed further. It's still a little bit primitive. This is a case, the next three cases I'm going to be very briefly touching upon. These are my personal cases. This is a 67-year-old Vietnamese lady with hepatitis B. You know, she had a segment 63.1 by 1.7. She had several imaging. It turned out to be an indeterminate lesion. She went on to have a biopsy done twice, and it showed negative HCC, and the AFP was borderline elevated. And in June 2016, when I joined Rutgers, the updated imaging showed 4.1 by 2.7 LR5. And so let me transition and pulling up her image for a second. And this is her image. You can see a nice lesion in segment 5. So some of the questions, so in order to address my third objective, which is how do you employ which platform? Well, some of the questions that I would be thinking about is, could MIS approach would have hastened this process? I mean, she has several imaging done, it still showed indeterminate, and then she had a couple of biopsy. Well, if I were taking care of her, I would have said, you know, with very minimal less morbidity, we could have resected this. And if so, which modality would you still do it laparoscopically or robotic platform? Could robotic platform help in non-segmental resection? This
Dr.
is the
Ayla,
only...
in the interest of time, we're going to have this probably be the last video for your section, okay?
Sure. And the reason I put this is because of the precision. Even though it's a small lesion, it can be done laparoscopic. also, what I wanted to show is the curvilinear dissection that you're trying to do in order to customize to the lesion, not just going to a standard mode of going in vertically and horizontally, instead a curvilinear dissection, very minimal manipulation of the tumor and also adjacent organs. And that is important because this patient is going to be high risk for developing another lesion. And if you would have to go back in, you want minimal adhesions as much as possible. So it's a quick go in and go out. And you can see the instruments are ergonomically very fit. So I think robotic lends itself very nicely to these kind of operations.
Now, for the fairness of the laparoscopic group, if you do have a laparoscopic video, I will permit one additional laparoscopic video.
No, the only thing I wanted to mention is, you have a 3.2 by 3 centimeters. Now, this patient can go into transplant, ablation, resection. All I wanted to say is at the end of it, with a minimal invasive surgery, externally at least, the operation, if done very well, it has minimal complication risk, and there's no subcostal incision. This is like, and nobody would recognize this patient had a hepatectomy done. They would think it would be a cholecystectomy performed on this patient. And the third case I just wanted to mention, Suzanne, is it's not just minor resections. It can be transferred to major resections. I'm sure other people are going to talk about it, so I'm just going to touch on it. This is a 72-year-old gentleman who had a very complex mass in his right lobe. I have one more slide and then I'm going to stop. I mean, you can appreciate this. This is a mass that it was involving segment 6, 7, 5, 6, 7, and to part of 8. Doesn't mean it's a limitation to MIS. This can be done by a trained surgeon in MIS with a very minimal complication as well. And I just wanted to share, this is his external appearance after a right hepatectomy. You can barely see his incisions, and the specimen is right there. Usually I do a fan and steel incision to remove it. So in conclusion, to respect other speakers' time, I just wanted to share, if anybody is interested in videos, I can email me. I will send the teaching version of these videos because I can't show all this in 8 minutes. But what I would like to make in conclusion is that MIS hepatectomy is safe and feasible in experienced hands and also trained by trained surgeons. Although predominantly currently laparoscopic and robotic platforms are being employed, it does show superior outcomes while maintaining oncological equivalence to open hepatectomies. And I do firmly believe that robotic platform has a role in complex HPV case, and sills and nodes are still experimental. Thank you for the opportunity.
Thank you so much, Dr. Alu, for that presentation. While you stop sharing your screen and Dr. Al-Saidi starts sharing his, we have some comments from the peanut gallery saying that you have set a great stage very well for the rest of our presenters. We also, I'll let the people watching on Facebook into a little rivalry going on in the comments section here between Drs. Al-Saidi and Dr. Sung. So I look forward to their little fencing match here as we move forward. Dr. Al-Saidi, we're so lucky to have you here today. Dr. Al-Saidi is currently at UCSF by way of Virginia Mason, so I have invited his colleagues here also to heckle him. You can see Dr. Helton sitting behind Dr. Rocha for those of you in gallery view. And Dr. Al-Saidi is going to talk to us about the advantages of laparoscopic liver resection. I should say, in addition to his well-known surgical prowess, Dr. Al-Saidi also took a tour of the world's best minimally invasive liver surgeons in the last several years. And so I'm really looking forward to hear what he has to say to us today. Adnan, thanks so much.
Thank you so much, Dr. Warner. So can you hear me okay?
Yes.
Perfect, thank you. So that was a very nice presentation. That's Spachini. Thanks for setting the stage there. And so I do teach for Ethicon, as you see below there. However, I won't discuss anything in this talk that is related to that. And so my task was advantages of laparoscopic liver resection. So technique, tools, learning curve, transference of psychomotor skills. So that's what I'm going to focus on. I'm not going to talk about, since it's not my task, in terms of outcomes, short-term or long-term outcomes. These are two QR codes, which you can just point your cell phone on or your smartphone on, and they're basically both talk about both long-term and short-term outcomes of MIS surgery, robotic or laparoscopic, it doesn't matter. And they're part of a postgraduate course that we held for between ILS, which is the International Laparoscopic Liver Society, and SAGES. So I encourage you to look at that if you are interested in that. And so, first of all, let's talk about learning curves. And this is great news. I mean, this is kind of like, May 4th. So a lot of fascinating things happen in May 4th. And we all know that, in the end, we have to be all collegial and say the truth. And I think most robotic people do robotics simply because they feel like laparoscopic surgery is too hard. And that's fine. There's good news for them. And so there's a lot of really good data on this to show that things actually have changed. In other words, how to learn to do laparoscopic major hepatectomies is much easier now than it was even 5 years ago. Let me explain. This is a paper that I was honored to be part of, and it was published in the Annals last year, that basically took the ideal methodology and basically compared learning, the role of the surgeon during the stage 2A, 2B, versus the role of the surgeon when they're earlier earlier adapters, which are in stage 3, which is what we are in now for laparoscopic liver surgery. And compared their learning curves, and not just time in the OR, we're talking about complications, recurrence, margins, oncological factors, and there's a huge difference. The early adapters learned much faster, easier, were able to progress from minor to major hepatectomy much faster, less complications than the pioneers, meaning that you can learn that today's surgeon can learn MIS hepatectomies in a much less of a troublesome manner than the pioneers did just 5 years ago. And this is not a surprise. A lot of things have improved. Hospital resources, technical ability in terms of simulation, team setup. You don't have to actually invent things. You actually have a platform that is stable, that is actually done, that people have actually published on, that's tried and true. So you can certainly learn from others much easier. You don't have to borrow from bariatric surgeons and so on. So in other words, at this point, really learning HPB surgery laparoscopic is not like what it was 5 years ago, and it's certainly much easier. And the point is that you need to have a standardized method of learning. So to try to learn this by going to a holiday and expense in a weekend doesn't make sense. But there's other ways to do this in a very structured platform that actually gets you there and gets you there safely. And the key is to have a structured mechanism that takes you through the first 5 or 7 phases of psychomotor learning. And after that, once you're at the mastery skill, then you need mentoring, practice, and feedback. And I've got 2 of my ex-partners up there, Flavio and Scott, and we work together in this. And it's actually not a difficult thing to do, even in settings where you're using old towers, old equipment. The key is to do this in a methodological fashion. So I find this as great news for a lot of the robotic surgeons, because you no longer have to do robotics anymore. It's actually pretty easy to now start doing it laparoscopically. So keep that in mind. Now let's talk about the setup and the tools. There's, in my mind, I'm not a robotic surgeon, but I've done some robotics. And I would tell you, when I do robotics, I realize that I lose a lot compared to laparoscopic surgery. Now, when I say that to some people, they think that I've lost my mind. But the truth is, there is a huge difference in terms of just size of instruments. And this is not a cosmetic thing. To be able to use a 5mm instrument, in my mind, to actually go around the portal vein, go around the bile duct, go around a small hepatic vessel, is really very important to me. And that's way more important to me than to have wrists, because I really can have a trocar almost anywhere I want. And if we actually lose this rigidity of thinking that a transthoracic trocar is a bad thing, then everything is game. So keep that in mind. Then you have the energy platforms. The robotics has harmonics, but they have a shorter arm, they don't articulate, and they're stuck in that same place. Now you say you can't articulate in laparoscopic. Yes, you can't, but you can have a trocar almost anywhere you want. And so you can, in essence, get there much easier. And a 5mm trocar, not an 8. And so that's important to me. The ability to actually clear the parenchyma, which is something that Dr. Sebastiani mentioned, is essential. Every single time I see a robotic surgery, I'm seeing it as incredibly bloody compared to laparoscopic surgery. And now I know we all edit our videos, but I'm trying to be very honest about that. You can actually clear the parenchyma, see every single thing you want to see, and then take care of it, whether it's with Hemalox, with energy, or with suture, very easily in laparoscopic surgery. I have yet to see that done that well in robotic surgery. Then you have the setup. You can pretty much, the sky is the limit. I mean, for God's sake, some people even do prone hepatic surgery laparoscopic. I certainly have not done that, but in terms of semi-prone, the Japanese position, the French position, the lateral, low lithotomy, supine, and so you can use the power of a lot of things to actually, of the gravity and of movement to actually help you. Now, if you're in a place where you can have you have your own robot and its access is not an issue and integrated with the bed, maybe this is not an issue for you. But the vast majority of HPB surgeons out there have either access problems or have an old robot or have a new robot without an integrated bed, so on and so forth. And this is not even an issue with laparoscopic surgery. And then, as Dr. Sebastiani mentioned, in very difficult cases, with distortion, you also have the access of assist, which I have to say that I prefer to people not to use it because I think it gets in the way. However, in certain cases, it can help you. So that's something to keep in mind. Other advantages is the transference of skill. Yes, it's true that you can have transference of skill in robotics, but again, access is an issue. Teaching and learning. I would rather have my fellows become proficient in laparoscopic surgery because then that can transfer to almost anything they do in the abdomen, but also they don't have the issue of limited tools and limited access. Assistance can actually help. Now, I say this, and I don't mean this in any disrespectful way, but you see a lot of people that do robotic surgery, and actually the bedside person is doing the surgery laparoscopically, which I don't understand. It's almost like double the cost. So it's either you can do it, and there are some people who are really proficient, like Dr. Sung, that can actually do a pure robotic surgery. But then sometimes you have this hybrid thing where there's a robotic surgeon and a laparoscopic surgeon at the same time, which in my mind is really just a waste of resources. Vascular control, hemorrhage control, which we'll talk about in a little bit by a video that one of our super fellows, Dr. Morgan Bond did. And then it's also cheaper, just to keep that in mind. And there's now randomized data showing that this actually is cheaper than open. Keeping things simple is essential. As Dr. Warner said, I've had the pleasure of traveling really to all over the world, kind of learning from who I think are the best out there. And one thing you see that people make it simpler and simpler instruments, and that's key. This is my setup. This is the setup of Virginia Mason. Basically, this is what we do: lap Whipples, lap livers. And to me, keeping it simple is key. You don't need anything really fancy to do this. In the end, you have to know your enemy, and I think the liver is very complicated. Whether you use the Japanese difficulty score or the British difficulty score, you have to understand that it's not just about the tumor and the location. It's about the liver, the patient, the chemotherapy, the cirrhosis. And when you take that on the mind, it transfers. It ends up, the key word ends up being flexibility. Flexibility equals control. And in my mind, MIS gives you all the flexibility because you have an array of tools. You have an array of positions that you could use. You have your assistant that can help you. There's just no limitations. And for that reason, you end up in a situation where you can actually have a completely right liver split in half, and you actually have two surgeons, in other words, 4 hands working in there. You have a hole in the right vena cava, in the right hepatic vein off the vena cava, like here. And guess what? It's one person is simply lifting up and stopping all the bleeding. The other words, the person is using a parenchymal removing tissue mechanism, whether it's water jet or CUSA, in this case in CUSA, to clear that vein so that you can actually see exactly what you're dealing with. And then the other person sutures. It's very controlled, that even in a situation where you actually have a major hepatic vessel bleed, you're still in control. I don't see that in robotics. And you have situations like this, where you have, where you can actually look at the heart in the right upper corner. This is Dr. Bond's video, that as you start transecting the liver, you realize that the heart is empty of any gas or any flow, and there's CO2, that's the 24 there, that's this capnography. And as you start going through the liver, you still are in a very good control. You can use fluorescence if you want, and you have very little bleeding. And in this case, we had a hole in a right hepatic vein, and that's the hole that you see there. And you can see there's significant gas in the liver, in the heart. This is an issue. If it was air, it would be deadly, but it's CO2. And for that reason, because you have your assistant there, because you're able to control this, you can take your time and control it with, in this case, with staplers, suture, whatever you want. There's a significant amount of opportunities and things that you could use to control even a major bleeding like that. So I will stop, and this would say that it's easier to learn MIS liver resections. So this is kind of a huge gift for the robotic surgeons, so they can, at this point, open up their to other fields. And then there's the MIS liver offers more tools, more options, flexible setup, which I think is essential for a very complex organ that has many different challenges, including non-anatomic challenges. It offers more options if challenges occur, if you have a problem, for example, a cyst. And then the platform allows for the use of assistants and for teaching that I feel is much easier done on laparoscopic than for robotics. And for that, I thank you, Dr. Warner, for organizing this, and appreciate all the feedback.
Thank you, Dr. Al-Saady, so much. I'll invite you to stop sharing your screen, and Dr. Sung can start sharing his. Dr. Al-Saady, since you ran over and I elected not to mute you, you have lost your opportunity to rebut the following comment from Jason Hawksworth, who said, you can use the CUSA during robotic hepatectomy. So if you want to try and rebut that comment at the end of the session, there will be an opportunity then. The other question that I would love for you to address at the end is one raised by Dr. Al-Hayek, which is, and I think you're extremely well qualified to answer this question, is there an educational pathway from minor to major hepatectomy that you would recommend for people to use? So I'll look forward to your answer to that at the end of the panel. Without further ado, I will introduce Dr. Sung from I'm going to say the instead of the from now on, I think, the Ohio State University, who's going to tell us about the advantages of robotic liver surgery. Dr. Sung, thank you so much for joining us.
Well, thanks so much, Dr. Warner. It's really an honor to give a talk today. I didn't realize it was supposed to be a debate, but I guess I'll threw the gloves down. So I'll try to add some things here. But reality is, I don't know if I should be talking about robotic or lab. I haven't done a MIS, liver surgery for 2 months, so I don't know. Maybe I'll start doing opens from now on. But I just wanted to talk a little bit about advantages of robotic liver surgery and what I call from myth to reality. I don't have any disclosures. And also, unlike Dr. Al-Saady, I'll try to keep on time. So this is exactly what Dr. Al-Saady is complaining about. So these are the skeptics for robotic liver surgery. I can do it faster and safer open. It costs too much with no added benefit. I can do lab liver resections. It takes too much time to learn. Yeah, those are all things that people have said, probably for the past 10 years. But they also said the same thing for laparoscopic cases. But obviously, things have changed as we start to evolve. So I think, everyone has heard about some of the adoption of laparoscopic liver surgery. There's numerous studies that support the use of MIS in liver surgery. Everyone has heard the benefits of less intra-op estimated blood loss because of the better visualization, fewer complications, whether that's true or not compared to open. There's definitely less post-op pain just because of not requiring subcostal incisions, and the length of stay in most studies have been shown to be improved. But I think what most importantly, the R0 and the 5-year overall survival has been comparable in resection of cancer laparoscopically for HCC and metastatic colorectal cancer, which are the two most common malignancies done for MIS liver resection so far. And as I think Dr. Ailu alluded to earlier, according to the second international consensus on laparoscopic liver resection, let me see. This was done in 2014. One of the results of this consensus statement was that Minimally invasive minor liver resection is now considered standard of care. And also, they also said that major hepatectomy performed via MIS remains an innovative procedure. But I think something that both Dr. Al-Saidi and I will continue to stress is that is this truly a reality? Our laparoscopic, sort of minor resections really standard of care among everyone? And also doing a major hepatectomy, either laparoscopic or robotically, is that really something that most people can do? And I think that's why, most recently in 2019, during the International Laparoscopic Society, one of the main emphasis is diffusion of these techniques. Sure, you come to these meetings, you have all the experts around the world showing all these awesome videos, but the question is, can most people around the world, around the country, can they do any type of minor or liver resection safely? And that's why I've always been a proponent of robotics for liver surgery. I've listed these 5 advantages, and before I used to put them randomly, but I actually put them in order of what I personally think are advantages. So I think the most important difference, if anyone has done laparoscopic as well as robotic, there really is improved visualization, especially with 3-dimensional. There's something that I really think is a huge disadvantage for laparoscopic surgery. You're born with 2 eyes, you have 3-dimensional vision, but laparoscopic, you're only looking at a screen, so you move and you lose that ability. I know that there are many, there's starting to be more technology where you can, wear these headset or, goggles to see 3-dimensional. But once you see that, there is a huge difference in any type of surgery, not just for liver. And also for robotic, you have the benefit of magnification. To me, this is the sort of one of the biggest advantages for robotic. And I know that Dr. Al-Saidi doesn't think, wristed instruments are, as important, but, not everyone is as skilled as of a surgeon laparoscopically as he is. But I think for the general person, it is very difficult for the Hilar dissection or, complex dissections that's needed. And anyone that's worked with the robot can realize that the wristed instrument is a huge benefit in being able to dissect. And then the third one, advantage is, you have the surgeon control of forearm stability. Yeah, you can have I think everyone knows that when you get to control a camera, you can get control of 3 arms, even a 3rd arm for, retraction, stable retraction. It's so much better than having, multiple people, holding a camera or trying to retract for you when you're doing it laparoscopically. And I think another advantage is the elimination of fulcrum effect. That is an inherent disadvantage of the laparoscopic approach for all laparoscopy. When you put in an instrument, because of the fulcrum effect, you move the instrument one way, but inside it goes the other way. But I think as people learn to be better laparoscopic surgeons, this is not as important. And one of the advantages that I really don't like when people say it decreases fatigue. I think, people say, well, I can have a cup of coffee and do robotics. Well, that's not really the purpose of robotics. I think there's definitely fatigue, especially when you're in a long case for, multiple hours. You can definitely get that, neck and shoulder pain, and even your wrist starts to, get fatigued as well. So to me, that is not as important. So what's important, I'll just give you an example of, what we show normally, these nice videos. This is an example of a gallbladder cancer, a central liver resection, and portal dissection. With all the different instruments, you can see that, there's I don't know what Anna was saying, but we try not to lose that much blood, and we try to have bloodless surgery as well. But also, if you look at it, with the portal dissection, I think that, you can see with just the wristed instruments, the visualization, it actually, to me, it facilitates, these fine dissections much more so than laparoscopic. Not to say that you can't develop this, do the same thing laparoscopically, but in terms of the learning curve, I have personally, seen, from residents to fellows, their learning curve is much shorter with robotic than laparoscopic for these complex dissections. But of course, this is exactly what Donna was saying. What we actually see when you go to these meetings, you see all these great videos, but reality is, there's also disasters that can happen in robotics, and this is what happens when, someone that may not be trained or have the support, you can actually have a lot of disasters. But as you can see, the one where you're suturing, you can actually have the wristed instruments can help with some of the suturing compared to doing it laparoscopically. And the one where we get into bleeding, where we, during the hilar dissection, we actually have to fix a hole in the portal vein, but using that stable retraction, that third arm that we mentioned, is something as an advantage where you don't have to have someone holding it, and because of a stable arm, you can actually, continue fixing the injury. But I will, be honest, I do have some disadvantages of robotic liver surgery. And I also put this in order of what I think. So I think one of the biggest disadvantages, we currently have limited instruments, but it's getting better. Don't forget robotics, most of the people using robotics are urologists and gynecologists, and it's starting to become more popular with general surgery, especially for HPV, especially with some of the XI and some of the new instruments coming out. I think, as we tend to evolve, not only ourselves, but also instruments, this will become better and better. Training is definitely an issue. I think what Dr. Alcidi, said before, I do agree. It's difficult. You have to be a liver surgeon first. You have to train to understand the anatomy of liver surgery. You have to know it open, but then laparoscopically and then robotic. It's very hard, for a resident fellow to, master all of these. But if you look at most studies for comparing laparoscopic and robotic, the education, the learning curve is definitely decreased with robotic techniques. There's also no tactile feedback, but as you become more and more facile with robotics, you can actually see things rather than having to feel things. There's also a need for a skilled assistant. I think that's true for laparoscopic as well. You can't just have a third-year medical student help you with a complex laparoscopic procedure. And same thing in robotic. You need someone that's skilled at the assistant at the bedside. And the costs, I agree. In the U.S. is about $2,000 to $4,000 more per each case, no matter what type of case compared to laparoscopic. But I think it's partly true because we have a stranglehold based on the current the company that's using it. But as we have a more competitive market out there, this will decrease as well. And we talked about evolution of robotic instruments. I know Dr. Alcidi said, he probably has used a harmonic that didn't articulate, but that was, probably 10 years ago. Now we have the endo-wrist vessel sealer, we have angulated staplers. And in addition, I actually like the robotic ultrasound very much. It's much better than a laparoscopic probe. You have the fluorescent imaging, Firefly, that can identify blood vessels and a biliary system. And also there's more and more systems coming out with virtual reality in robotic liver resection. So I think, at the end of the day, I don't think robotics should overtake laparoscopic. I think robotics can facilitate complex MIS liver surgery. And what are these complex resections? These are, major hepatectomies, also with tumors in unfavorable tumor locations, such as the posterior segment, superior segments, as well as caudate lobe. But also, as I showed in some of the videos before, bleeding control, I think, is a lot easier with robotic than laparoscopic. And these are just a quick example. I know time is coming out, but this is an example of a segment 7 tumor. You have the patient on the left lateral decubitus. We're able to resect that. It's very difficult with laparoscopic because you don't have the wristed instruments, but I find that it's a lot easier with robotic to get it underneath the rib cage. And same thing with fine dissection, hilar dissection for, say, like a major resection, left hepatectomy. You can see, you can get, the visualization, 3D effect. The wristed instrument has a huge advantage. So I just want to end with caution in surgical evolution. Some words of advice that I've learned. So the next great thing does not excuse poor judgment. That goes for both laparoscopic and robotic. Just because you can doesn't mean that we should, because many of us really can't. I think it's true. I think one of the things I do agree with Adnan is you have to have a structured program, whether it's laparoscopic or robotic. If you don't have a sort of a structured program of training, a structured program of how you break up the cases to different segments to be able to teach not only trainees but also other surgeons, it's going to fail. And finally, the one thing to remember is that the potential benefit of an innovative technique for the surgeon should not override the patient's benefit. Thank you.
Thank you so much, Dr. Sung. So we do have a just blown up comment section here. Um, so a little bit of everything, but one of the most interesting questions I think for our viewers would be, what is everyone using for parenchymal transection? So what do you guys typically use? We have Dr. Martini here commenting that he likes the vessel sealer with the fenestrated bipolar. What is your preference, Dr. Sung?
Yeah, so I do the same thing that I do for open, and I like the sort of the crush clamp technique. So I agree with Dr. Martini that I mean, I'm similar to him where I use the bipolar to crush, and then the vessel sealer to coagulate.
Okay, great. So we'll have Dr. Rocha share his screen, and while he does that, Dr. Al-Saidi, if you want to jump in and tell everybody, do you always use the CUSA, or is there something else you prefer for parenchymal transection laparoscopically?
For any major hepatectomy, we use the CUSA. For minor hepatectomy, just because the CUSA is a little bit more of a setup issue, we just use the harmonic and what's called a poor man's CUSA, where you basically use it to kind of remove some of the tissue so you could see what you're going through. But for major hepatectomies, yes, always.
Thank you. And we'll focus a little bit later on when we talk about education about rolling out a program together. But without further ado, I'd like to get to Dr. Rocha's presentation. He's going to tell us all the data. Thanks so much, Dr. Rocha, for being here.
Laura, you're muted.
Can you hear me?
Yes.
All right. I'm trying to practice social distancing, but I don't think I can talk with this mask on. So, and we have a little multi-generational setup here in my office with Dr. Helton and Dr. Kirks, who's our fellow. So, but the point of my talk is to just kind of give, I don't want to say curb the enthusiasm, but just give a little balanced perspective on what the data, or at least the randomized data, shows us and tells us about MIS and open hepatectomy. Let me see if I can figure this out. Okay, I have no disclosures. So MIS liver surgery, I mean, I think as the other speakers have covered, it's really promises a lot of results. So it promises a faster functional recovery, reduced blood loss, fewer complications. I think specifically MIS liver surgery has lagged behind other sites in the GI tract, like the colon or the stomach, really because of the technical difficulty and the case complexity. Unlike down in the rectum or in the pelvis, you really need to mobilize and retract a solid organ. There's potential for significant blood loss, as Alan nicely showed in his videos. And I think as the other speakers have also alluded to, there's a lack of a dedicated training platform, as well as which technique to use. I do think things have come a long way. So some of these factors that have helped kind of the adoption of MIS hepatectomy, including the staplers, the CUSA has been mentioned, all the other bipolar radiofrequency devices for both laparoscopic surgery and robotic surgery, as well as the fact that you have pneumoperitoneum and better low central venous anesthesia, all help to kind of minimize the blood loss with the MIS approach. So just to give a little historical perspective, and this was in that nice review article that Dr. Ailu presented earlier. Really, the first MIS partial hepatectomy was only done in 1991. So as you can imagine, there's not a long time that this has been around. That was followed by the first left lateral sectionectomy in 96, and then the first hemihepatectomy in 97. What's influenced the field the most, I think, are these consensus conferences, and I think some of these have already been brought up, including the original Louisville statement, the Morioka conference, and then also in Europe, the most recent one was the Southampton consensus. I think this is, as we know, a group of surgeons coming together with basically expert opinions. So I find it a little, I would say, forward to say that these panels can come up with standards of care when a lot of this was, a lot of the randomized trials, as you'll see, have come out later than the actual conferences were held. And I think that's the problem in really rigorously evaluating the benefit of MIS surgery is just the lack of randomized controlled trials due to the obvious difficulty of patient and surgeon and disease heterogeneity, and obviously the significant selection bias that's involved in designing these trials. So let's start by looking at probably the most three, at least the three kind of most substantial trials that have been done. And you'll see, starting with the Orange 2 trial, which was actually failed to accrue. This was the first effort in trying to really standardize and randomize patients to a left lateral sectionectomy. And this was done in Europe. And they tried to randomize patients, however, only were able to accrue about 29 patients. And the reason that the DSMB shut the trial down is it seemed like there was a significant bias towards laparoscopic surgery. So a lot of the surgeons just felt that there was not enough equipoise. But in the 29 patients that were eventually randomized, there was really no difference in length of stay, morbidity, or readmission rates. Probably the best trial that was done is the Oslo Comet trial. And this was a single center trial out of Norway. It was initially published in 2018 with a follow-up and now in 2019. And this was 280 patients, all with colorectal liver metastases. But you'll see it was all relatively minor hepatectomy. So this was actually designed for parenchymal sparing surgery, less than 3 segments. The primary endpoint was 30-day complication rate, which did indeed favor the laparoscopic group at 19 versus 31%. But you'll see OR time, blood loss, margins, and mortality was not different. The only other secondary endpoint that was significant was the length of stay, which was indeed reduced. And I found it interesting that the authors actually put it in hours as opposed to days. So 53 hours versus 96 hours. But really what they looked at, the length of stay, was really more a proxy for cost efficiency. So in the paper, which we don't have time to go over in detail, they had the quality adjusted life years. And it appeared that if you were randomized to the laparoscopic group, this was more cost efficient. I think more interesting was the follow-up paper in the British Journal of Surgery in 2019, where they, instead of looking at the short-term outcomes, actually looked at long-term outcomes. So quality of life scores were actually included as part of this randomized trial. But you'll see that the largest benefit was seen really at 1 month, where the MIS group had better scores in 4 domains. However, longer term at about 4 months, that dropped to only 1 domain difference in quality of life. Most recently, the smaller Lapapuva trial, which was also done in a single center in Spain. Very experienced group, 204 patients, again with colorectal liver metastases, and again, smaller liver resections. The majority of patients had segmentectomies or sectionectomies. However, left hepatectomies were also allowed in the trial. Their primary endpoint was also postoperative morbidity at 90 days, which was indeed reduced in the MIS group of 11% versus 23%. But these, interestingly, if you read in the paper, were mostly minor complications. The serious morbidity was actually equivalent between groups. Again, you'll see the theme here, no difference in OR time, blood loss, transfusion, or mortality. And there was, again, a length of stay reduction in the MIS group of 4 versus 6 days. Interestingly, they did comment on Pringle time, so that the MIS group did have about twice the Pringle time than the open group. Moving on to different disease sites. So in hepatocellular carcinoma, this is the only trial that we have to base things on. And this was a study out of Egypt. It was actually initially presented at the HPVA as a plenary session. And it was laparoscopic versus open, solitary HCC, less than 5 centimeters in child's A cirrhotic patients. It was 25 patients per arm, so a relatively small study. And the vast majority of lesions were actually located in segments 2 and 3. Again, kind of highlighting the fact that most of these trials are done in minor hepatectomies, left lateral sectionectomies, which are easier approaches. And then the other 30% were in segments 5 and 6. So really no patients in this trial were in the more difficult superior or posterior segments. Their primary outcome was length of stay, and you can see the secondary endpoints there. And again, the results showed, like the other trials in colorectal liver metastases, that the MIS group had a shorter operative time, but really a shorter length of stay, 2.4 versus 4.2 days, but no difference in blood loss, complications, R0 resection rates, and then overall survival. So what about the rest of the data that we have available? So at least for major hepatectomy, there are no randomized trials. There are, though, a bunch of systematic reviews and meta-analyses of individual patient data. And this is probably the best one that's out there that was published in Surgery in 2018. So again, keep in mind that these are basically individual studies. They may or may not be comparable, but they do have somewhat strength in numbers. And you can see there are 917 patients that were then split between lap and open groups in 8 retrospective studies. I included the table just for ease of interpretation. And you can see out of the factors, the majority of factors were actually equivalent, things like complications, mortality, overall survival. The ones that did have a difference, meaning longer operative time for laparoscopic surgery, but less blood loss and a shorter hospital stay, you can see the heterogeneity was quite substantial in those groups. So it's really hard to make those cross-study comparisons. But I think this is a good start to perhaps then design a future randomized trial in major hepatectomies. This was actually an early systematic review, probably in the beginning era of robotic liver surgery. And this was actually one of my, a Dutch group aided by one of my former mentors, Dr. Fong, who also happens to be Dr. Warner's boss. But you'll see here again, a retrospective study, pooled analysis. But the interesting thing to look at this table is see how many are minor resections versus major resections. And if you look at the length of stay, which seems to be the most purported benefit of robotic surgery or MIS surgery, you can see that the length of stay is actually quite comparable, at least in this series, to what it is in open surgery, so 5 to 7 days. If you then go on to larger resections, you can see that length of stay jumps up to about 11 days. And so you start thinking, perhaps maybe this is not the panacea that we think of. But I really think the line at the bottom, which is in the summary results of the paper, really shows that the greatest potential clinical benefit of the robotic platform lies in the minor resections of difficult located places. So I think as Dr. Sung had mentioned, those tumors that are high up in 7 and 8, that yes, a subcostal incision might be less preferable than to 3 or 4 robotic port sites. What about other disease sites? Well, this is where it gets a little muddier. So if you look at Hilar Cholangiocarcinoma, there's not a lot of data out there, but there is at least a systematic review looking at what studies are there available. And you'll see that the majority are really case reports, video abstracts, really a mix of laparoscopic, robotic, and hybrid procedures. And you can see the conversion rates are high. The hospital stay is not significantly different than open surgery. And certainly the robotic cases showed somewhat of a longer operative time, length of stay, and blood loss. But it's really hard to interpret these results given the significant heterogeneity, different patient cohorts, different experience, and so forth. I think the same is true for intrahepatic cholangiocarcinoma. So again, not a lot of prospective randomized data here, just a few systematic reviews and meta-analyses. And this one particular, which is just in press and JOGS, 6 retrospective studies, including a large NCDB study that looked at 384 patients with laparoscopic surgery compared to 2,000 patients with open surgery. And what you can see, which is different than colorectal liver mets, is that in intrahepatic cholangiocarcinoma, laparoscopic hepatectomy is associated with, interestingly, more R0 resections, but a lot less major hepatectomies. And what was interesting to find for me was the fact that there were not only lower rates of lymph node dissections, but also lower number of lymph nodes that are resected during laparoscopic hepatectomies. And these were also performed for smaller tumors. Again, no difference in perioperative results or survival, but I would say the quality of the data is not as robust. So I think in summary, what we can take from the current state of affairs is that MIS hepatectomy can be performed with good results in specialized centers. I would say that the randomized data supports its benefit in short-term perioperative outcomes for minor hepatectomies in colorectal liver metastases. I think its effect in major hepatectomy and for HCC is still unclear, although I think hopefully to be developed in the near future. For cholangiocarcinoma, it's really more of a challenge. So the need of routine lymphadenectomies and sometimes bile duct dissections or resections have really kind of put off somewhat the advance in MIS hepatectomy for this disease and really has not been well studied. If you ask me, I think the best way to study this process is with expertise-based trials. So instead of randomizing patients to one or the other, you actually randomize patients to the best laparoscopic surgeon versus the best robotic surgeon versus the best open surgeon. Because then you really evaluate the technique necessarily, and you get out of things like learning curves, institutional biases, and so forth. Which I think brings me to my last point, and I hope that this group will take on this challenge, is to really kind of define what should be the learning curve, what should be the training program, is there a preferred platform, and if you run these kind of trials, are the results going to be reproducible and applicable to the general public? Or do we think that MIS hepatectomy should be done in select centers of excellence where there's the expertise, experience, and so forth? With that, I'll thank you for your attention.
Thank you so much, Dr. Rocha. That was a really great tour de force in educating all of us as to what's out there. I'll invite you to stop sharing your screen, and then Dr. Secondy can share his. While we're doing that, we will update what has happened in the comments board. Basically, Dr. Martini has told us that eventually, once you're good enough, you may not need a educated bedside assistant or somebody that's educated beyond in terms of school. I assume his technicians are extremely well educated in liver and pancreas surgery after having spent many hours with him. But he is actually has now developed a system where he's able to sit at the console with his fellows as he has trained some very skilled technicians. I think for the rest of us mortals, while we are ramping up to that level, I think most of the comments would agree that there's a lot of bedside assisting going on. And I would invite some discussion from the panel as to Adnan's comment earlier that many times we're actually doing robotic surgery with one person at the console and then another person at the bedside doing laparoscopic surgery along with it. I thought that was an excellent comment. Dr. Rocha made one point about hard to reach areas being really great for the robot, and we would agree. In addition to the paper that you cited from my boss, Dr. Fong, there's another wonderful paper from my boss, Dr. Fong, and Lale Maelstrom, who is one of my colleagues here at City of Hope, talking about the use of the robot for what we have coined incision dominant cases. So otherwise, you know, these giant incisions for these tiny little tumors. So if anybody else wants to pick that term up, hashtag incision dominant, I think it's a really great way to help people understand the use of the robot and where it has a great utility for our patients. So we're gonna finish strong here. Dr. Sakandia and his group need no introduction to the SAGE's audience with Dr. Ross and Rosemary's excellent legacy that they've left us. I'm really excited to see some of his videos. He has already volunteered to me that he plans to run long. So Dr. Sekondi, I'm planning to interrupt you around 7 minutes to remind you what time it is. But I know we're all really looking forward to seeing your videos. So without further ado, please enlighten us as to how we do robotic hepatectomies in Florida.
All right. First of all, thank you for the invitation. So I was asked to talk about tips and tricks of robotic hepatectomy. The difficulty of preparing this talk is only 8.5 minutes. So I'm trying to go as fast as possible here. I have no disclosure. The only thing is Dr. Sung trained me how to do liver surgery during my Pittsburgh time. So it's a big credit for him too. So tips and tricks. So first of all is I think as a surgeon, you have to be patient because there's a lot of learning curve. If you rush it, you probably will create more bleeding than what you need to. Robotic surgery is a computer-assisted laparoscopy, so you know it's basically follow the laparoscopic principle as well. I think you need to manage bleeding before you keep going because you may create more bleeding by doing that, and then you may not be able to control it. And always start with a minor resection, peripheral segment 2, 3, 4, 5, 6, and then go to left lateral section. Left hepatectomy, caudal resection, right, extended hepatectomy, ALFs, and then classic tumor resection. We have done all of them, and we try to follow this sort of stage. What I can tell you is a robotic system will make the portal hepatitis dissection a lot easier, and the fistula repair, bile duct repair, hepatic oxygenostomy will be a lot easier as well, and also management of intra of the bleeding disasters. IVC, right hepatic vein, and all that. So tip and trick. So this is one of the instruments that we like the most. This is a vascular bulldog clamp made by Scanlon. It comes curved, it comes straight. It is useful to get inflow control for a major hepatectomy. Pringle maneuver is rarely needed. We have not done Pringle in the last 200 cases of robotic hepatectomy. We like to use the pediatric sponge laps in case we get bleeding or our embolism. We can just put the sponge against it. When the sponge is wet, it will be watertight. It will close all the holes that can suck the CO2 into the heart. The CVP, we still use the low CVP. Everybody gets central line, and we use the PEEP down to 0. I learned from Briscoe. I spent 3 weeks in Paris with him. And I came back to Tampa, and then I know that if the PEEP is low to 0, the bleeding is much less. And talk about the bulldog clamp. Anatomy is most important, and 2 things. One is the portal hepatis here. The surgeon has to really master his portal hepatis. The second is intrahepatic anatomy. This is the setup for right hepatectomy. So you can see the pictures there. This is the camera port for right hepatectomy. The camera will be 2 centimeters to the right, 2 centimeters to the head, so not right in the umbilicus. So this is for robotic arm 1. gel point here for the system to work. This is a single site system, and a camera here, 3 and 4. And we use this for formal right, partial right, segment 7 and 8 resection, right adrenalectomy, which we do a lot as well. Patient is a 12-degree reverse Vandenberg and 5-degree tilt to the left for the right hepatectomy. So I'm going to show you, this is not the most spectacular clips that we do. The intention is so then everybody can learn from sort of relatively straightforward procedures here. So this is the how we do isolation of the portal hepatis for the right hepatectomy. You can see here we use the vessel sealer, bipolar and hook cautery a lot. This is the right hepatic artery here, and this is the right pole vein here. It is approached from the right side of the portal hepatis. You can see here we come around the right hepatic artery very easy with the robot. And we put a clip here, hemolog clip, 2 on the staying side, 1 on the going side. As soon as we cut the right hepatic artery, the portal vein is widely exposed. Usually there's no difficulty at all doing this. This is you can see the carotid lobe right here, main portal vein right here. We clean from the top part, from the back part, and then you can go around it with essentially a bloodless, and this is relatively simple as well. This is a 6-inch trio silk that we utilize to sort of ligate first, so then it bunch up the pole vein. You can easily place clips after it get bunched up like that. Without it, sometimes you feel like the clip is not big enough for the pole vein. So now 1 clip on the going side and then another reinforcement on the staying side. As soon as this is get cut, part of the session is over. This is pretty straightforward with the robotic system. This is the second video. This is also an isolation of the inflow for the right lobe. The reason why is because the anatomy is a bit different. We all know that the right hepatic artery travels posterior to the common hepatic duct in about 80% of the patient, but sometimes they don't. And this is the case where they don't. This is 20% where it's crossing anterior to the common hepatic duct. You can see here the hook cautery and bipolar lift up the right hepatic artery, goes behind it, boom. Now right hepatic artery is behind the silk suture. We just put the little hemolog there because we're gonna do a bulldog clamping for this one because this is only a partial right, not a full right. So we try always to try to get some sort of inflow control as possible. You can see here, this is the pole vein dissection. Always, sometimes there is a segment 6 branch here. You can see here, we go around the right hepatic, pole vein quite straightforwardly with robotic Maryland dissector and place a suture around it. It is important to use to retract the common bile duct to the medial aspect, and this will expose the portal vein very easily with retraction of the bile duct medial. You see here, this is robotic arm 4. We utilize robotic arm 4 to sort of pull up on the bile duct a bit to the medial side, and then the portal vein is right there. Now I move on to the parenchymal transection. For the superficial, we use the scissors. For the deeper, we use vessel sealer, clip, or stapler. So this is the superficial part of the parenchyma. We use the monopolar scissor cutter. This is at 7 of the setting. This is the carotid extension being transected here. This is the superficial part of it. The bedside assistant is sort of sucking the smoke out. So this is the deeper part. We utilize vessel sealer. You can go a bit slow. Usually the bleeding is a lot less. You can see here, this is not bloody at all. And I said this is just regular video that I picked up, not too much editing and this and that. So you can see there, very slowly, bit by bit, we advance the operation. So you can see here, there's a crossing branch there. So I think it's important to try to recognize that before you just lacerate it or create bleeding. So it's important to try to see every single crossing branches, and you don't need CUSA for this. Now move on to the right hepatic ducts. In most right hepatectomy, we utilize the stapler, except when the tumor is really close to the bifurcation, that we dissect every single branch of the bile duct. But otherwise, in most, I would say 90% of right hepatectomy, you can just staple off the right hepatic duct, no problem. And this give you a very low incidence of bile leak. So you can see here, this is, we still use a laparoscopic stapler, but now we're moving toward the robotic stapler. This is an older video, so this is still laparoscopic stapler. This is the purple load of the EndoGS 60. So after we transect the bile duct, the liver will open book. I think what is keeping the liver for the right hepatectomy not to open book is the bile duct. As soon as you cut the bile duct, the liver just open like that. Next video, handling of the hepatic vein branches intrahepatically. So again, this can cause significant bleeding, even conversion to open. However, please do not rush doing this. Take your time and do it well. Okay, you can see.
Speaking of not rushing, we're going to wrap up the videos here pretty soon. You're at 8 minutes.
Okay, so you can see there we identify the vein and then put clip and use a vessel sealer for this. And now this is the right hepatic vein here. You see the right hepatic vein there is being stapled. Okay, we can do it all under visualization. Again, no CUSA in this kind of maneuvers here. We can just do it with straight robotic. Okay, and then this is how we remove the specimen. This is like the French group. Sort of we split the parenchyma first, and then you do the attachment last. And you can see it's pretty straightforward here. Next, I'm gonna do one video of left hepatectomy. This is about 2.5 minutes. So this
I'll
is
allow it.
It's okay? No? Stop?
Yes, it's okay. We'll allow it.
So this is a left hepatectomy. It's a bit different because the left hepatectomy, the frame is shifted to the left a little bit. So here, okay, perfect. So now this is the mobilization of the left hepatic lobe. You see here the robotic arm 4 is very, very useful to lift up the left lobe of the liver. Again, the portal dissection here by the robot is extremely easy. This is the station 8A common hepatic artery. Just like Whipple, we always remove it. This is the left hepatic artery being skeletonized here. You can see the portal vein behind it. We're gonna transect these 2 clips on the staying side, 1 clip on the going side. Again, just like on the right side, as soon as the hepatic artery is gone, the portal vein, you cannot even miss it. So this is the portal vein here. This is the caudate branch here. We're gonna ligate distal for the caudate branch. And again, you can see here, again, the trio silk around the portal vein here. And I move up the video a bit quickly here. You can see the video here. Now this parenchymal transection here. Boom, boom, boom. The superficial part of it. Okay, now back to the parenchyma again. I think this is a bloodless operation here. So you can see here the parenchymal transection with the vessel sealer. You go bit by bit, try to see all the intrahepatic branches if possible. Your assistant is doing some suctioning at the bedside, not much suctioning though. You can see here. And then once we arrive at the bile duct, we staple it. Now the only thing you have left is the left hepatic vein. Sometimes you require 2 staples. So you staple a left hepatic vein here. There's a bit of left, a bit part of the left hepatic vein. Another staple, and operation is over. This left hepatectomy can be done in about 1 hour and 45 minutes with about 50 cc of blood loss. Very straightforward, and I think it's easy for people to learn how to do this. Okay, now this is a very quick 45 seconds clip here. This is a segment.
Okay, this is the last one.
All right, last one. Segment 8 resection here. You can see the scissors followed by the vessel sealer going down. It's a bit oozing on the bottom part. This is the very cirrhotic liver you can see on the background there. I talk about the pediatric sponge lab. This is very important. If you have bleeding, you can use it to tamponade, and you just suture it up quickly. This is pre-Hilar suture, and that's it. All right, and the video is.
Those were beautiful. This is exactly what we you at the end because I knew you would hold everybody's attention with amazing videos. Thank you so much. So I wanted to bring up a few things that have come up in the comments here. So one thing that's come up in our comments with the group is reiterating that as we become more facile on the robotic console, and Iswanto, I'll invite you to stop sharing your screen. So as we become more facile on the console, that we need fewer assistants at the bedside, and that obviously decreases the expense when you're not taking up two surgeons' time. But another comment that was made was that when we get more facile with the robot, we tend to use fewer staplers. I know a lot of us, our initial experience with the laparoscopic liver resection is Bovie till you can't stand it, energy device till you hit something, and then staple till it's over. That's what we see from a lot of our less experienced colleagues and sometimes from our more experienced colleagues. But I wanted to get Dr. Sung and Iswanto's comments on how much are you using the stapler now that you are more facile robotically, and then I'll get Dr. Alsaidi's and Dr. Alu's comments and Dr. Rocha if he wants to weigh in on staplers.
Iswanto, I'll let you go first.
So for left hepatectomy, it's 2 stapler, sometimes 3. For right hepatectomy, 3 to 4 stapler. And for non-anatomic, no stapler. Used to be at the beginning of the learning curve, we use a staple quite a bit, especially when I was in Pittsburgh, we use a lot of stapler. But then I traveled to see a lot of places, Europe and Asia and this and that. And we sort of like try to do this operation as meticulous as possible. You can see the crossing branches. We used to sort of less care about them. But then as we gain more experience, we know where they are, so we can find them more easily. And this is without CUSA. I mean, CUSA is helpful. I use CUSA for open hepatectomy. But for robotic, we can actually get away from not having CUSA, even though the robot is making CUSA right now. But I think as you gain more experience, you just know where the fest is going to come. So you can use a lot less stapler.
Dr. Sung, so Iswanto's describing using the anatomical force. How are you able to know what you're about to run into?
Yeah, so I think it's all about visualization. I think that with it's not only magnification, but also the 3-dimensional, we're actually looking for the vessels. We're not just randomly doing it. And I think also one of the main reasons why I switched from laparoscopic to robotic was sort of the way I was trained for laparoscopic. It was, just go through, a centimeter and then staple, staple, staple. And we use multiple cartridges. But robotic, you can actually, to me, it's more similar to open, where you can, crush, clamp, dissect, see things, and then you don't run. And if you get into bleeding, you can control it. Whereas laparoscopic, sometimes it's a little more difficult.
Do the other participants have any stapling opinions, laparoscopically or otherwise?
If I could add, this is Adnan. I think it's important. I really enjoy listening to everyone, and I think we all are talking about doing things the safe way. But I have to disagree with a couple things, if I could. First of all, to say that we actually can know where things are based on experience, I think is not the right way I think about it. I don't think it's safe to do it that way. I think no matter how much mapping we have and no matter how much experience you have, there's significant variability that you need to actually, it's all about visualization, like Dr. Song said, and you have to be careful that way. And in my mind, the idea of actually being able to remove the parenchyma is key. Whether you do that with crush crank technique, or whether you do that with water jet, whether you do that with CUSA, it doesn't matter, but you have to do that, because if you don't see, you will have complications. And there are significant complications in this field because of that. Now, whether you shed the parenchyma with one of these techniques, whatever you feel is best, then at that point, you take it with clips, or you take it with a stapler, or you take it with energy. It doesn't matter in my mind, because it's just a matter of cost versus how fast you want to go. Sometimes if you have 3 veins in a row, it's faster just to use a stapler, but that's different than just blindly using a stapler, which I think we're all saying that that is not the right thing to do.
I think in order to, Susan, to comment on your question, you can prepare as much as you can with preoperative imaging, but at the end of the day, when you are in the operating room, you can visualize the best robotics can offer us. but one has to be prepared when they encounter especially hepatic vein bleeding, to be able to control it quickly. And suturing is the best technique for me. And I think that's what computer-assisted platform lends you because of the ergonomics those needle drivers have. You can suture it. The reason I say that is because sometimes you can have a bleeding from the horizontal portal vein branches that are going, and the vein could have retracted. So you're no longer seeing exactly where the hole is, but there is bleeding. In that case, the simple maneuver is put a sponge. You usually have a Resection or something inside, so you use your pressure, and then get your needle driver and take a deep bite, and that's how you control it. So yes, staplers are great. You can prepare yourself and memorize the mapping on the patient that you're going to be operating. But at the same time, you have to be prepared to suture the bleeder regardless.
Thank you, Dr. Alu. Anything to add, Dr. Rocha?
Well, I was just going to mention, I mean, obviously, you know, the majority of what I do is open. I'm more of a wedges on the edges when it comes to MIS hepatectomy. But I'm more curious since we have this master panel here, is what are the things that get you to convert? Because, you know, bleeding would seem to be, it's probably better to fix it laparoscopically or robotically because you have that pneumoperitoneum. Whereas from what I've heard from other very experienced laparoscopists and robotic surgeons is the last thing I want to do is convert to open because you'll really lose a lot of blood in that conversion. And I'm wondering if you got any 3 or 4 of you guys can comment on that.
I absolutely agree with Flavio. When you're doing it, whether it's laparoscopic or robotic, and you have to emergently convert, you're actually going to cause a lot of problems because all of a sudden you're opening up, you lose a pneumoperitoneum, you lose, you know, you put whether it's a robot or a retractor, a laparoscopic retractor, you're trying to, you know, stop the bleeding, and then all of a sudden when you open up, you lose all the pneumoperitoneum, everything, you know, goes away, and then all of a sudden you have massive bleeding. So whether you do a laparoscopic or robotic, if you cannot control bleeding, you shouldn't be doing it. And that's one thing that I don't care whether you do lap or robot, that's like sort of the number one, you know, skill set you have to develop. For me, the two most common reasons why I convert, one is failure to progress. For some reason, it's just taking too long. I can't seem to get it, you know, to make any progress. Then I just convert to open. The second one is if I feel oncologically, I don't think, you know, whether with ultrasound or, you know, as I'm dissecting, I'm not really sure, then I just convert as well. But for bleeding, you know, I agree. I try not to, you know, emergently convert just for bleeding.
Let me just add to that, if you don't mind, Dr. Warner, is that I 100% agree with that. Remember that picture or the video of the right heart with a hole in the right hepatic vein. That is significant amount of CO2 in the right heart. You convert to control that kind of a hole, and then you basically exchange that with air, and that much air, or even much less than that amount of air in the right heart, would be a significant physiological insult. So certainly the idea here is control the bleeding. You don't have to continue with the case MIS, just control the bleeding and then convert if you have to.
Yeah.
Iswanto or Sebastian, anything to add?
Sure. I appreciate the comments that Adnan made, you know, having a very experienced surgeon at the bedside. To be quite honest with you, Adnan, at an academic center, I don't have that resources of having 2 attendings do the cases. So usually I will have a 4th-year resident who rotates every 2 months on our service assisting me. But what I can tell you is from because of the way my career path has took, I think I was more comfortable operating with the resident in doing these cases, and I have become a self-sufficient to rely on the bedside person who is assisting. I keep that assistance to very minimum, usually for suctioning or bringing in the needles. But everything else with the 4 arms, which is 2 times what God has given me, I'm able to control it. In terms of conversion, Suzanne, looking back at my own case series, the times that I converted is when I have strategically misjudged my strategy how to approach a lesion. Sometimes in order to save the liver parenchyma, instead of approaching it head on, with my resection line, I would go head on straight line and then jump a little bit towards the horizontal, and then found myself that I can't visualize better. And then now I had to convert it to open. So it's a very hard learned lesson, but having that experience, now I know how to strategically position my camera and the resection line.
Dr. Warner, if I could say something about that, I think it's important. It's very important. I think what you mentioned, Dr. Subashini, is very important. And the idea is, and this is not about ego or anything like that, it's about what's safe. You know, the key here is if I have one of my partners like Dr. Helton or Dr. Rocha operating with me, it's a lot of fun, and we're operating together, it's a lot of fun. I would say that the vast majority of the time, we don't have time to do that. And so you're doing it obviously with a fellow or a resident. And that's also an incredible amount of fun if you have a team that is designed to do this. But the key is safety. If I don't have the team that I feel is comfortable, in other words, if I have a resident and a nurse that actually hasn't done this, I would actually change that to an open procedure. And I tell my patients immediately, I tell them, look, you have two options, either we cancel or change it to an open, because the key is to actually be safe. Last thing you want to do is have an assistant that doesn't know MIS, HPV, and a scrub tech that doesn't know that, and then you get in trouble. That's a disaster. Dr. John Martini is actually on this as well, and he's developed an incredible method of actually doing robotic pancreas and liver with actually very little assistance. And I think the way you design your platform, the way you design your curriculum is essential. He also has a curriculum for teaching fellows and residents, and I think it's important for us to do this right way. And again, it's not about saving resources, it's about doing it safely.
Thank you, Anand. So on that note, I think this is a great opportunity for our last and final question of each of the panelists. So what I'm hearing you say is that it's extremely important when you roll out a minimally invasive hepatectomy program, whether it's laparoscopic or robotic, that you do so cautiously and in a multidisciplinary manner and in a way that involves all the stakeholders in the hospital or in the operating room at the very least. So on that note, there's a lot of data out there, much of which was generated by Dr. Sung and his colleagues about learning curves in robotic surgery. So could you all please share with us what you felt like your learning curve was until you could comfortably do anatomic lobes, and what is your current conversion rate for anatomic lobes, and what was it when you first started out? So you guys could enlighten us. We'll start with Dr. Sung.
So conversion rate, it's pretty consistent now. It's probably about 5 to 10% for major resection. And the other question was, when did I become comfortable with major
Yeah, about
resection?
how many cases with your current platform did it take before you could do majors?
So it's different because I did a lot of laparoscopic before, but with the robot, I would probably say, just like a lot of literature shows, probably about 50, 60 cases robotically, not just with liver resection, but with other types of robotic cases where you become more and more comfortable.
So 60 touches on the robot, not necessarily 60 major livers.
Yeah, but 60, like not just gallbladders, but either pancreas surgery, like complex surgeries.
Okay, great. Eswanto?
For me, it's for a major hepatectomy about 50, and this is assuming having done open major hepatectomy, maybe 100 or so. And conversion rate, we've done about 245 right now of robotic hepatectomy, 60% of our major, and conversion rate is 0.5%. Dr.
El-Saidi.
So for us, it was a little different, again, because it's an MIS platform. There's a lot of transferability. And so I divide my cases into 3 buckets: open, planned conversion, and then MIS. And the planned conversions are things, for example, like cholangiocarcinomas, like Hilar. I don't believe in doing those laparoscopically because the margins are very critical, very small. I still do them open, but I would start laparoscopically, rule out any mets, mobilize the entire liver, and then have a midline incision instead of a Makuchi incision. And I do that also for any case that I actually feel like mobilization will help me minimize the incision and things like that, and avoid a negative laparotomy. For pure MIS that I actually decide to do it MIS from the beginning, conversion rates is probably about 14% or 13. And I would say that it took me about 30 to 35 before I started feeling comfortable with doing major livers. And I say that mostly because, again, it's the same platform for pancreas. And so I think that helps me learn.
Thank you. Dr. Alu?
It's a little bit challenging to answer that question, Suzanne, because of my MIS experience before, tons of experience. But I can tell you, I almost cried the first time I did an open hepatectomy in my first case in my fellowship. When I saw those muscles were being like transected, I almost cried because I was, I knew that these operations can be done MIS very fluently and with less complications. So I would pass that question from my end because I was like, when can I start doing these MIS cases? As soon as I finished the fellowship, I was so ready for it. So it's hard to judge for me.
Dr.
But having
Rocha,
said that, when I did start the cases, I usually do it with a fourth-year resident, but I have senior transplant surgeons that I always tell them when I'm doing a major case to be just around, just in case if I need their assistance. I still do.
one more question for Dr. Rocha, then we'll finish with Dr. Al-Saady. Dr. Rocha, for your wedges on the edges, how long did it take you to feel comfortable doing that?
Yeah, I mean, I think, obviously it was always nice to have Dr. Al-Saady and Dr. Helton around at my beck and call. So that certainly helped. But I think, as Adnan did mention, it is a lot of that's transferable skill. So certainly, the skills that you learn doing lap bariatric surgery, lap distal pancreatectomies, I think they all transfer. I think the liver is a little bit more challenging, as we talked about, as far as positioning and so forth. Major hepatectomy is a different story. And so certainly that, I think, takes another level of skill to do that. And so what I would say is my challenge would be for this kind of group of master surgeons, and certainly for the members that are live, is how do we move forward for this? So should there be a curriculum, a learning curve that's standardized? Are we then able to design a proper randomized trial to really get into the benefits of this? I mean, if we look at the experience in pancreas and look at how, things like the LEPR trial were very methodically designed, but in the end, when you try to apply that to a general population of surgeons, even with a learning curve, you could see that there was some issues then with the results and interpretation of the study. So I would think, with this group and certainly with the rest of the membership, how do we move forward? And I kind of throw down a gauntlet to make that happen.
Thank you. We'll pick up that gauntlet in another webinar because we're running very short on time. Dr. Sung, before I get to Dr. Al-Saady, I know you also have some curricular development under your belt. Is there any resources that you would point our viewers to when they're trying to teach junior learners about being on the console and being safe?
I don't have anything that's widespread. I think the most important thing, if you're going to be starting someone, is to have a senior sort of partner or a colleague that can sort of guide you and be there as you're starting your MIS experience.
Thank you. And then Dr. Al-Saady, earlier we alluded to the minor to major education platforms that are available. So going from minor to major hepatectomies. If you could enlighten our viewers, and then there are some comments going in the Facebook feed asking Dr. Martini to kindly share his fellows education platform. And we'll certainly invite anyone to continue commenting on this webinar if they have any resources available for early learners, late learners, for anybody. We're more than happy to see it. So Dr. Al-Saady, do you have any recommendations for our viewers?
Sure. I mean, I certainly defer to Dr. Song and Dr. Martini with respect to robotics, but I think there's a lot of similarities when it comes to MIS in both arms. I think the first step, which I think most of us can start doing safely right away, most surgeons, is to start developing a team, developing a platform, developing your sets, and start doing minor hepatectomies. I think those are safe. The chance of actually a major catastrophic issue with minor hepatectomies, like Dr. Rocha said, inferior hepatectomies, segments 2 and 3 and 4 and then 5 and 6, is very low risk. And I think those are probably a good place to start so that you can actually build your team. Once you've done that, how do you take that step and you go to major hepatectomies? I would tell you that there's many platforms out there that actually, many ways that people have done it, but I think the key here is to do something that is actually continuous and not episodic. So the one thing is you could do a fellowship if you can, and then many people are doing fellowship even after practicing. The second, if you can't do that, then you need to go through a methodological program that actually has mentorship and a curricular design, and actually somebody that's going to help you beyond going to a weekend thing. That may mean going through a year-long program, and we're offering those year-long programs, but also going through a SAGES master's program. The key is to have a curriculum and have a mentor that actually is going to help guide you through the challenges that are going to happen. Once together you've built that and you feel like you're ready to take on a major hepatectomy, the key is selection, and to have somebody help you in the first case, in the first few cases. I think that's essential. I do not, as I said in the beginning, I do not believe that this is an insurmountable issue. I feel like it is much easier now than even 5 years ago. But the worst thing you could do is do it in a non-methodological manner, have a major complication, which not only will be horrible for your patient, but certainly horrible for your practice. So that's what I would recommend.
Thank you so much, and I want to thank everyone, all of our participants, all of our panelists, all of our viewers who tuned in live. We are going to put this on SAGES YouTube once it's all said and done, and I want to take this opportunity, in addition to thanking our panelists for taking all the time and doing this. These were excellent presentations. I'm so excited to have learned from all of you today. We also have another one of these webinars coming up on May 13th at 7:30 p.m. Eastern, 6:30 Central. Dr. Tim Vreeland of BAMC in San Antonio will be moderating a discussion of all things MIS oncology for HPV. So we're going to have a talk on HCC from Catherine Tay in Manila, biliary cancers talk from Dr. Cow in Houston, pancreas cancer by Dr. Kubi, and colorectal liver metastases by Sean Clary. So please tune in next Wednesday. Is it next Wednesday? Wednesday after next, the 13th. And I'm sure we'll have another rip-roaring great time in the comments section at the very least. So thank you all for joining us. Stay safe and comment in the Facebook comments section for further discussion. Thanks, everybody.
Thank you.
Thank you.
Thank you.
Now,
Thank you, Susie.
Thank you. Okay.
Are we off?
We are off of Facebook now. Yes.
Suzanne, that was awesome. Thanks so much for organizing this.
Great job,
work.
guys.
Really phenomenal.
No, you guys were amazing.
8 minutes.
I'm sorry, but it doesn't hold attention. Actually, 2-minute videos online is what's supposed to get it.
So short.
Alan, for the record, Kevin Hayek sends me a poster at my presentation where it says, "There is no benefits to MIS, just do it robotically." So I got all fired up.
I don't believe that. So.
I would say you really practiced it with a short time that Suzanne gave you. We knew about this for 2 weeks, and you were like put in like
a bottle of
48
wine.
hours.
That's what I did.
I thought you were going to pull out your boxing gloves and punch all of us, you know?
No.
You guys were amazing. Thank you.
Susan,
Thank
you're
you.
awesome.
Thank you.
Thank you.
No, I'm sorry to
Honestly,
have been a policeman about this, but we
You
were
are
supposed to
tough.
stay within 90 minutes, and we did. Thank you very much.
That was
Just
perfect.
barely. I was trying to get us all out of here in an hour, but it's not even 5 o'clock here, so I'm
Yeah.
not being punished like you guys are.
Thank you,
Great.
folks.
Thanks, everybody.
Take care.
This is
Bye.
fun.
I'm going to
Thank
stay
you.
on for a minute, so you guys can go ahead and leave.
Okay, bye.
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 Okay, so I forgot to hit record at the beginning of this, so I'm going to go ahead and introduce this so that when Ed puts it on YouTube, this can be part of the intro. So welcome, everybody. Thank you so much for tuning in to Facebook Live for our All Things MIS webinar. I'm so excited to welcome our esteemed panelists, Dr. Elu from Rutgers in New Jersey, Dr. Adnan Al-Saidi from UCSF, Dr. Alan Sung from The Ohio State University, Dr. Flavio Roca from Virginia Mason, and Dr. Iswanto Sekondi from Tampa, Florida. We're very excited to talk to you about all things MIS today. Thank you so much for tuning in. I'm going to hand over the floor to our first panelist, Dr. Elu, who's going to talk about the benefits of minimally invasive liver surgery, both robotic and laparoscopic. Thanks so much, Dr. Elu, for joining us. Okay, Ed, you can stop there. Hopefully you can edit, maybe not. Okay, thanks.